Greetings, everyone. I'm Dr. Joe Robertson, and my topic to speak to you about here is congenital oral atresia. It's a condition that we have quite a bit of experience treating, and as you'll see, there are some excellent ways to evaluate and treat children for the hearing component of this condition. The information that you will receive today is a compilation of information that we have put together over 20 plus years of treating patients with this condition. We've done now over 120 conferences around the world in a number of different cities and have met parents from really all walks of life with children with this condition. And we also have done over 3,000 surgeries, and those patients have come to us from over 65 different countries. So the information you receive it has changed over the years. It's state of the art as to where we are right now. Our medical practice is in Northern California. It's the California Ear Institute, or CEI Medical Group. We're located just south of San Francisco in Palo Alto, California, which is right adjacent to or envelops Stanford University. And our center, the International Center for Atresia and Microtia Reconstruction, is located in the bottom of this building with easy access to local transportation facilities. Let me tell you a little bit about myself. I'm trained originally actually in general surgery and trauma surgery, and then switched into ear, nose, and throat surgery at Stanford University, and then completed a fellowship both in Los Angeles and then a rotating fellowship in Europe in skull-based surgery and neurotologic surgery. So the area of expertise that I've had to deal with over my career are base of the skull lesions, brain tumors, hearing impairment, cochlear implants, and then this last phase has been atresia and microtia. I've been the director of Stanford Otology and Neurotology for 10 years and then left in 2004 to go into the private world, where I felt like, and it's proven, we've been better able to care for our patients than in some of the larger organizations here in the United States. And as I said, the International Center for Atresia and Microtia Repair is really the third iteration of my career, and we have among the world's largest, if not the largest, experience with atresia and microtia in terms of evaluation and treatment. And let me introduce you to my family. I show you this for those of you that have been to conferences before as years go by. We have in the bottom left Haley, who many of you know because she's a physician's assistant with me, and she is scheduled to be married in August of 2020 to Doug. This is my oldest daughter, Caitlin, and she has just announced that she's scheduled to be married in the fall of 2020. And this is my son, Baxter. He's a middle child, and his wife, Margaret. And they've been married for a couple of years, and they have also something neat I'll show you here in a second. And this is my wife, Julia. We just had our 37th anniversary. And I like to show you this because I like to talk to you as both a scientist and also as a father. I like to tell you what the data is, what we could do, why we should do it, but I like to tell you what I would do if this were my child, and I think that really centers it. I'd like to introduce to you the first member, or the newest member of our family, Luke Robertson. That is my son Baxter and his wife's Margaret child, and he was born in the beginning of July of 2020, and that's his little ear at about 2 or 3 days of life, and there the little guy is in person. So we've had quite an enjoyable time seeing that. Let's now talk about atresia and microtia, and really it should be correctly termed atresia and microtia because there are two separate conditions. The oral atresia is the malformation of the ear canal and the eardrum, whereas the microtia is the malformation of the outer ear. And the reason we like to call it two separate names is they don't always occur together. You will see most of the time the ear canal and the outer ear are malformed together, but you also will see sometimes a normal outer ear and an absence of an ear canal. Curiously enough, you don't ever see a normal ear canal and no outer ear. So in that situation, they really are two related but distinct conditions. So here is something you need to understand. There's a separate lecture which we've recorded, and many of you have seen this already, on auditory development. And the take-home messages from that are critical. It's a complex subject that is really important if you understand it. So if you haven't watched that lecture, find it and watch that as well. But here's the take-home from that 25-minute lecture, is that normal function in life requires 2 ears. If you don't have that, it's going to impact you. In fact, it's going to be a disability. and that the development of brain function, vocabulary, and many of the things that children develop over time depends on sound. So if you're missing sound in one or definitely both ears, then that can have a huge impact on the way a child develops. And it is important early in life to institute that sound, because there's a critical period of development that's in the first 5 years of life for children that are very important for them to be able to develop normally. Now, we've talked about in this other lection hearing and development. So this is going to focus on evaluation and treatment and results of the hearing system. So our goal in evaluating a child is not, can we provide hearing to an ear or to both ears? The question is, how can we provide hearing? Because it's almost always the case that the inner ear is present, and there is some mechanism to get hearing to that inner ear. As you'll see, sometimes it's creating a normal canal in the eardrum, sometimes it's using a hearing aid, sometimes it's an implantable hearing device. There are many different options which you'll understand as we go through this talk. So a little history for you is, when we first started this process, you looked at the medical literature, and you talked to people, and you go to conferences, and it was very clear that the evaluation of a child with atresia microtia was hodgepodge and just all over the map. So one of the things that we developed early on is a system to make sure we cover that completely in each child. And our goal with seeing you today, and as we need as time goes by, is to fill in these different areas. There are 8 categories of evaluation, and we've got an easy way for you to remember that will help us to know what to do. Now, I'll go through that in just a minute, but let me say this. There's some varieties of atresia. Most of them are single-sided, 90% of the time. Boys are more affected than girls, and the right ear is more affected than the left ear for some reason. About 10% of patients have bilateral atresia, and that's obviously a big impact because the child can't hear on either side. And you must, capital MUST, must use bone conduction hearing devices early in a child's life in that situation to stimulate and to get hearing to the inner ear. There's a band with a vibrating device that can be placed on a child's head that will pick up sound, it will vibrate, and that sound will go through the bone directly to the inner ear. Now, you can also have a partial atresia. So some patients have a very thin ear canal, partially developed ear canal. In fact, sometimes it can start to develop and then wall off and actually cause a tumor. I'll show you here in a few minutes. Those are rare, but partial atresias do occur. I mentioned the next bullet, the normal outer ear and no ear canal. And then in 23% of our cases around the world, there is also an abnormality of the face beyond the ear on that side. That can be the soft tissue of the cheek, it can be the jaw, it can be the bony structure of the mandible, which is the lower jaw, or the maxilla, which is the upper jaw. So about 1 in 4 patients will have some asymmetry one side versus the other. Not every one of those needs to be treated, but they can be treated. The bone can be treated, the soft tissue can be treated, and that's something that we can discuss with you individually if that's the case. Now, this is a publication, if you want to take a little snapshot of that, if you want to look it up later, that I put together with some of my co-authors that was published in 2013. We began to use this now about 12 or 13 years ago in evaluation of patients. There were 742 patients we'd evaluate at that point. Now we're well over, I think, 4,000 or 5,000. So it's come in very handy. It allows us to do a couple of things. Number one is communicate from physician to physician. So when I speak to a plastic surgeon, for example, and I list off all of these 8 characteristics and the evaluation of each, they know exactly what we're dealing with. It also, and probably more importantly, it allows us to look at the categories of each of those, and then as we follow patients later, to see how well we did with that combination of characteristics. This condition, frankly, is one where you should not always say yes, for example, to a hearing canal or to an ear canal, because sometimes the anatomy is unfavorable. It doesn't work well because there's not enough space, or it might even be risky depending on the way the anatomy developed. So those are the things that have allowed us to look back and to make some of these conclusions, which you'll see over time. And here's that system. We use the acronym HEARMAPS, HEARMAPS, and we will fill this in for you as we see you today. There are two objective tests that we have to have. The rest of them are on physical examination. And the hearing test is one of them, the H, which is here, and the atresia score, which is based on a CT scan. You see that as the third area down there. I'll show you each of these as we go through the presentation. But let me say this. Don't worry if you don't have all of these things today. That's not uncommon. For example, if your child is too young for a CT scan, we might have everything defined except for that A in the HEAR maps, the first A in the HEAR maps, and that's an important one to decide what to do. So it may be that we have a plan that when your child is old enough, a CT is done, and then you can send that to me. I'll be happy to read it for you, and then we'll fill in all of these so then we know which way to go and how to deal with that. So first of all, a hearing test. What's done, if you've ever seen this, is the first thing we do is we put a vibration device on the bone, usually behind the ear, and that vibration is transmitted through the bone directly to the inner ear or to the cochlea. You see the red arrow pointing at the green snail-shaped cochlea in that image. And we test different frequencies. And in the hearing test on the right side, called an audiogram, you see the vertical lines of the low frequencies, which are 250 hertz up to 4,000 hertz. Speech, by the way, falls from about 500 up to 4,000 hertz. And normal is in the gray shaded range. So between 0 and 30 decibels is normal. You see the 0 line. That doesn't mean there's no sound. That just means that that's the average lowest sound that a human can hear. And then as you get louder, up to 120 decibels, which is a really loud sound, then that graph goes further down. So you'll see the red triangles, which is a graph of the inner ear function, which in this patient is normal. Then when you have an ear canal blockage, as you see pictured, the green arrow, the sound doesn't get through the bone until you turn it up loud. If you turn a sound up loud enough, the child can hear it. It'll actually go through the bone and directly to the inner ear. So you see with the green circles now that the level of hearing is about 65 or 70 decibels, which is quite a ways down there. It also explains to you, for example, some parents go, okay, this makes no sense. If I get really close to their ear and speak loudly, they tell me they can hear in that ear. And they're right. What's happening is you're transmitting a loud sound through the bone to the inner ear or the hearing nerve on that side. This gives you some reference. If you were to put your finger in your ear and listen while I'm talking, that's at about 35 decibels or so. So atresia is quite a hearing loss on that side. I'm speaking now at about 40 to 55 decibels, somewhere in that range. So they would not be getting any of the speech or any of the sounds that I'm making with my voice right now in that ear if they were listening with the atresia ear. So the outer ear is graded in 4 different categories, and you'll see some of this with our plastic surgeons. Grade 1 is the mildest, and grade 4 is virtually no outer ear. Most of the ears that we see are grade 3, so usually that's the E score that we see. And then the CT scan is a critical part of development. You'll see a CT scan here that is done in this young man. At the top, you can see he's turned to the side. His left ear is normal, and his right ear is a grade 3 atresia and microtia. And if you look at the right arrow here, the red arrow, you'll see there's an opening that is a normal ear canal. So that's a normal scan. And then if you look at the other side where there's the grade 3, you'll see that there's no opening at all. So where there should have been an ear canal, there's nothing. So that is a complete atresia. Now what we've done is that we've take CT scans, and by the way, this has to be read by me personally. I will not give a score, and I definitely will not operate on anyone where I have not read the scan myself. It's critical because I see scans all day long every day, and a radiologist might see 2 of these in a year. So they'll do a report, and I respect their judgment, and they're fantastic at some things, but they're just not experienced enough to give us the score on this one. So I need to score that myself. And what we do, as you see this animation, or as we walk through, is the scan cuts at different layers. So as we go up and down, I can paint a 3D image of what that looks like and what the space is like. You see, for example, coming right where this arrow is, these are the middle ear bones right there. And this is the cochlea there. So I will give a score on that CT scan with points given to different areas. So the outer ear, if that's normal, it gets a point. It's not critical that you remember all of these, but just so that you know that the maximum score someone can get with a normal ear is 10. If they have microtia, an outer ear abnormality, the maximum score they can get is 9. As you might expect, the higher the score, the more likely we are to get a good result with surgery. And actually, this is what we use. So if a patient's under 5 with a score, you get hearing with an ear canal so rarely that, in my opinion, it does not make any sense to do that. So 1, 2, 3, or 4 are not candidates for an ear canal. They are candidates for hearing. Hear that clearly. Everyone is a candidate for hearing. And they're a candidate, for example, an implantable hearing device, as I'll show you in a few minutes. People that have 6, 7, 8, 9, or 10 have a very good or adequate chance of success with a canal, and we will recommend an ear canal surgery as the treatment of choice in those individuals. Again, this is based on the CT scan. And in some patients who have a score of 5, we can use, for example, a middle ear bone prosthesis and get good hearing. In some patients, you can think of this as a gray zone, really. Sometimes we'll recommend surgery with a 5 and sometimes we won't. We're more likely to recommend surgery with a 5 if the patient is bilateral, because any hearing in that situation is of help to the patient. But those are the numbers that, based on the CT scan, that we would do. And sometimes patients ask us, which is appropriate, is, are there any really urgent situations? And the answer to that is yes, there are. There is a tumor. I'm going to show you more of that in just a minute, where it's called a cholesteatoma, where the ear canal tried to form and the skin cyst forms deep in the bone, and that can enlarge. It can actually erode into the brain or other structures or become infected, and sometimes we have to operate on those quickly. In fact, I'll show you in a few minutes an image from a girl from Australia who had that situation. And then the second one is that there is a possibility that an atresia ear can get an infection. That's a question I frequently get from the audience, and the pediatricians are always wondering, can you get an infection in that ear? And the answer is yes, you can. If you think back to that scan that I had, there's airspace in the middle ear space, and fluid and infection can get into that, and you can sometimes have extension of that infection, and we have to drain it quickly. So there are a few urgent cases. So with the HearMap system, the last 5, the size of the earlobe, the mandible, which is the lower jaw, the soft tissue or the symmetry of the face, is the cheek the same on both sides, whether the facial nerve works well on the side of the surgery, and also any genetic abnormality or syndrome are important in filling out that completed HearMaps component. So again, that's our goal. Here's a young man who's from actually the Netherlands, but he's adopted, who is had his surgery with us on his right side. He had a repair of a grade 3 ear. That's his CT scan that you see at the top, where there's no ear canal. And his grade, I'll explain it to you, the H, or hearing, was 1.6. The 1 tells you that the inner ear is normal. The 6 tells you that he's hearing between 60 and 70 decibels. He's an E3, a grade 3 outer ear. An A8, which is a CT score of 8. That's one slice of it, and we would look obviously at, like you saw the animation or the video, up and down through the ear to give that score. The R is the remnant earlobe. We use that to reconstruct. That's normal, a 1. His mandible is symmetric, so that's a 1. The soft tissue is the same on both sides, so that's a 1. That's an A1. He has no paralysis of his facial nerve, which is 1, and he has no genetic abnormality or syndrome, so he's an S1. So that's his score, and he, as I mentioned, he decided, or his mom helped him decide, to have a combined atresia microtia repair, and the picture shows you his evaluation. So now let's move on to treatment and to talk about what options we have. I'm going to show you some of the photos from treatment, including some things from the operating room. But as you go forward, the first question you should ask yourself is, who do I need on my team? And this is the answer to that. Is first, as a pediatrician, I like those to be local. because you need immunization and well-child care and all kinds of different things. But you need one that at least wants to know something about Atresia microtia. Most pediatricians have never seen a patient with this, but that's if you know someone who has some experience, that's really valuable. You need someone who can do hearing testing in children, and those are specialized folks called audiologists. That would include things like implantable hearing device programming or hearing aid programming if they're needed. You need an otologist, which is what I do. You need a plastic surgeon if there's an abnormality to the outer ear or with the outer ear called the pinna. And then in a situation where jaw or facial reconstruction is needed, then a craniofacial surgeon is someone that we add to the team that can help us with that. For example, in our office, there's a surgeon who invented the device that lengthens the bone of the jaw when that's needed, and that can be done if it is indicated in your situation. So what's your first step as you see a child? The first is testing the hearing. We want to know two things. We want to know, is the hearing nerve normal in the affected ear? And for those of you that have unilateral conditions, we want to make sure the quote-unquote normal ear is actually normal, because we've seen around the world that in about 1 in 4, 27% of patients, the normal ear has a problem too. It's really easy to overlook that. So don't forget to test the good ear. For those of you that have single-sided Atresia microtia, we need an evaluation for congenital syndrome. Our website has quite a bit of information on that, and that's a long lecture in and of itself. But you generally will go to 2 people for that. One is your pediatrician, or there's a special genre of pediatrician in some developed countries that are known as developmental pediatrician, and pediatricians, and that's what their focus is looking for genetic or syndromic or developmental abnormalities. You need a speech and language therapist or a school therapist or someone who allows you to evaluate your child's speech and language. Speech development and language development, that's the bottom line of good hearing. Now, speech and language development will lag about 6 months behind hearing. So, for example, a child that doesn't hear well, sometimes if a parent's not savvy or on it, it'll take a year or 2 to figure out something's going on because the child doesn't develop language, and then people begin to look back at the hearing. Fortunately, in most countries now, hearing is screened at birth, so we pick that up early. And then I think it's great to get an early consultation. Many times we have people at these conferences with a child that's 2 weeks old. And in fact, we operated on a child from Europe recently that had been to 3 conferences by the time they had surgery. And I think that's fantastic. Gather as much information as you can. This information does change as time goes by, so that's important to stay up with it. And you want to plan with your otologist early on to say, what do we do next? And you need someone to call when you don't know what to do next or when it's hard to interpret something. The surgical candidacy is determined at 2 or 2.5 years of age with a CT scan. And what we have to do is we have to let that inner ear and bone develop enough to see what the anatomy is going to be. When you're a little tyke, like I introduced you to Luke, my grandson, he doesn't have much in his middle and inner ear, or his inner ear is present. He doesn't have much in his middle ear right now. So that will just develop like crazy over the next 2 years. And then with a CT scan, we can determine if surgery is possible. So here's your beginning of a flow diagram. The CT scan really determines whether or not we can do an ear canal. Again, grade 6 to 10, that's when we do it. And grade 1 through 5, typically we go with an implantable hearing device. Occasionally with a 5, we'll do or recommend an ear canal, but we'll tailor that on your own individual situation. So let me show you briefly with implantable hearing devices, and maybe more information on this in other areas. But the things that we use, all of them are very similar technology. And what they do is they take sound from the outside world, a microphone picks that up, it transmits it through an electronic device to something that vibrates and transmits sound to the inner ear. It's a lot like we do a hearing test, but this is a permanently implanted one. This one is made by MED-EL. The vibrating portion of the device is here. You see the top left with the green dot on top of it. And this is the antenna there, where in the bottom right you see the external portion that has a battery, and it transmits the sound across the skin. There's nothing showing through the skin. So that's one of the devices we see. There are 2 companies that make very similar devices, Baha and Ponto. And in that situation, this post is embedded or inserted into the bone, and the body grows into that. And then there is a metal receptacle that comes through the skin. You see an example of that here. You see an example of that there. And then the hearing device, which is different colors for different hair colors, will clip to the external device. It picks up the sound, has a battery in it. This vibrates. The sound is transmitted from that through the implant to the bone, and again is transmitted to the inner ear. This is also made, called a Baha, made by the same company, where there is nothing coming through the skin. If you look right here, the same processor is present, but the skin is intact, because what's happened is there's been a magnet that's implanted here, and then there's a magnet in the processor outside. So nothing comes through the skin. This one has an advantage of less infections. The sound is a little less crisp as the direct connection, but it's good. And here the device is in place. And then a more recent device is called the Ossia system. It's also made by the same folks, the Cochlear Corporation, which is an Australian corporation that makes the Baha, both the Baha Attract, which is the magnet, and the Baha Connect, which is the direct implant. And this device is again anchored to the bone. The skin is intact over the device. There's an external processor that sends a signal across to the internal device, and then the vibrating component is here. It's the exact same strategy as the Medel bone bridge, but this one is a little different in terms of its structure and shape. And then let's not forget that hearing aids can sometimes be extremely helpful. For example, if we have a patient who has an ear canal or no ear canal, we create an ear canal and hearing has improved, but we need a little bit more. It's very simple to fit a hearing device and use that device in the ear canal. And that's sometimes a lot simpler and actually more effective than using the implantable hearing devices. And we'll talk a little bit about that. That's a very nuanced difference, but I'll show you later on why we say it. Okay, and let's talk a little bit about the canal surgery or canalplasty. And what you're going to see over the next few minutes here is we're going to try to turn that, which in this patient has blockage of where the ear canal should have been. You see this is full of bone. There's no outer ear. We have the middle ear bones present, and we have the inner ear present. So our goal is to open this and make an eardrum and line that with skin, so that now as sound comes in and strikes that drum, it will transmit through the middle ear bones after it strikes that eardrum, which we have to reconstruct, through the middle ear to the inner ear, and then the inner ear transmits it from the cochlea to the brain. So one word about the timing of this. In earlier years, the first way the outer ear was reconstructed, in fact, most of the reconstructions around the world are still done this way, pardon me, is the rib graft reconstruction technique, which includes removing cartilage from the child's chest. Usually the child has to be 5 or 6 years of age or older for that to be large enough to harvest enough cartilage. Outer ear reconstruction is done first. Usually it's 3 or 4 surgeries. In our sequence, it's an average of 3.6 surgeries. And then the ear canal reconstruction is done. Typically, and the average in our population before some of our newer techniques was about 12.6 years. You can imagine with what you've heard about early intervention of hearing, especially if you watch the other lecture, that's puts us behind the 8 ball a little bit in terms of the development of speech and language. The other 2 options get hearing in early. The second one, the second red bullet, is the ear canal first, and then that's followed by outer ear reconstruction. The minimum gap between the two is about 4 months. Usually we like to see 6, but 4 is the minimum. And the ear canal will establish sound right away. That can be done at 3 years of age. And then the third option, which we have a lecture on a little later, is a combined atresia and microtia repair. And here at California Ear Institute, we're the first group in the world to do that. And as far as I know, the only group that's really doing it right now, where we do the canal and the outer reconstruction at the same time. And that also can be done at 3 years of age. So those are your decision points. Really, if you decide how you want to reconstruct the outer ear, then it will tell us what sort of timing we need with the ear canal. If you select rib graft reconstruction, which is viable, that's a reasonable thing, it usually means that we've got to stimulate that inner ear for those first 12 years, usually with a type of hearing device in addition to getting the outer ear done before we do the ear canal surgery. So this is a paper that I published now in 2009, so quite a while ago, that detailed a number of patients where we have done the ear canal surgery first. I was the first surgeon in the world to do that, and the reason we pioneered that is so that we could get hearing in before the critical period expired. And what I was seeing was a number of my patients, I would get a beautiful hearing test, and they would come back and they would just say, it just doesn't help me. And what we found is when we tested them in noise particularly, that ear didn't add much to their function because they were still functioning like they had a single ear. They were beyond the critical period. Their nervous structure or neural structure or hearing pathway had sort of stopped its development in a rudimentary phase, and the brain couldn't use that new information. Well, what we've seen since we've done ear canal surgery first is that the brain develops normally. So when we get a child, let's say to 15 years of age, if they had had a canal surgery first, they'll function normally in noise. Whereas if they had had the ear canal surgery at 12 and a half years of age, let's say after a rib graft, then they never improved to normal in background noise. So this has been an excellent change in the way that this surgery is and should be done. All of these little icons are papers or journals and societies around the world that have recognized that paper as and have published it. So let's talk a little bit about the surgery. There are 5 different scenarios where we do surgery. The child needs to be 3 years of age and 15 kilograms. That's our goal. Sometimes we'll go a little less than that on the kilograms, but about 3 years is when we do this. And the different situations, the 5 scenarios are this. Number 1 is there are some times when the outer ear is normal and there's no ear canal. And that's the case here. This is a patient who had something called an 18q- syndrome. So if you have a child with normal outer ears and no ear canals, talk to me and get some information about this potential syndrome and its evaluation, which we can test for and know if your child has. This is a patient who had a rib graft and then had an ear canal afterwards. You can see from his age, he's probably, I would guess, 8 or 9 there on the first photo, and then probably 2 or 3 years older on the other side. And then the next scenario is the ear canal surgery first. A young boy from Korea, American from Korean heritage actually, who has grade 3. And you see in this bottom left is his surgery. He was about 5 to 7 days after the surgery. That's the sponge that stays in the ear canal for a week or 2. This is an older technique because you see this incision that we used to make behind the ear. We don't do that anymore, as I'll show you in a few minutes. And this is him after he had the outer ear reconstructed. The next one is the combined surgery, and this young girl has a grade 3. You see where the ear is going to go, as we've marked here. You see the blood vessels that we'll use to cover the outer ear prosthesis. This is a picture from the operating room where the ear lobe has been rotated and saved. The porous polyethylene implant is under this. Then there's a tissue flap over the top of that, and then skin over, and then here is the sponge in the ear canal. And here is her result after she has healed. That's called a CAM, or combined intrusion microtia repair. And then the question comes up, people say, well, maybe we should just get the outer ear done, and then later we'll get the ear canal done. And that's a really bad idea for 2 reasons. One is that doesn't take advantage of the developmental period for hearing, which is not good. And then the second is that the complication rate of making an ear canal after the implant of the porous polyethylene is much higher. We do not recommend it. There's some patients that had an outer ear done, they didn't know how tough hearing would be, and we have done a number of them, and we can, but we don't recommend that as a standard for those 2 reasons. Now, there are several things that we need in the operating room for success. Very highly technically difficult surgery, but it's one that when you do it a lot, you get very good and predictable results if you know when to say when. The first is a facial nerve monitor, and during the surgery, we come close to the area where the facial nerve traverses. We see that on the CT scan, so we know where it is. And there's a monitor that we place after a patient goes to sleep. If we're coming near the nerve, then the monitor will alarm. It picks up the stimulation. The nerve will fire, the muscles in the face twitch, and the nerve turns that into an alarm for us. So that's helpful. We also find that the middle ear bones can be altered with a very special type of laser. And that's absolutely critical to do this safely, because it used to be that people would use a drill to do that. And that's not the smartest thing if you think about it, because the middle ear bones are designed to take any vibration, and speech and voice is a tiny vibration, and transmit that to the inner ear. So a drill would sound massively loud if you were awake, and that can actually injure the hearing nerve in the inner ear. So laser use is critical to that. And this is, as I've said, one of the more difficult surgeries. You get a very good result in selected patients, but it's hard to do revision here. And I'm referred patients around the world constantly who've had one attempt, and we can sometimes do a good job in fixing it, and sometimes it's very hard. So I like to tell parents to select carefully. And I realize that's a little self-serving, that comment, but it is true, because where you have that first surgery done is a really important decision. And then people say, well, okay, what's the chance that you're going to need a second surgery? And in our experience is 6%. And that's due to a malformation in the middle ear bones. I'll show you more about that. We were the first group in the world to show that as a problem, or why there's a problem. And in some cases, that requires the second surgery. So let's look a little bit at the operating room. You'll see a child. Here he's on his back, his face is turned away, and you're going to see a view looking straight down at the area where the ear canal should have been. Now this is under the microscope, and I'm going to show you first a diagram and then a video image. So the ear canal should have formed right here. This is a right ear, very similar if you think back to that CT scan that I showed you. The jaw joint is just in front, and the area where we're going to create a canal is right here. And that's what it looks like under the microscope. You see the jaw joint there, and the ear canal should have been right here. So next what I'll do is take in my right hand, a drill that has diamond chips on it, in my left hand, a suction irrigation. And what happens in the left hand is fluid is flushed through the area in the small pipe, and the larger one suctions or takes away those chips. And then in my right hand, I'm sculpting or creating that ear canal in the shape that it should have been. We're now deeper, so the suction irrigation is smaller, and this drill for sizing is 1.5 millimeters in size. So this is quite high magnification. And you can, I think, perceive that we're deeper. I'm removing some bone right there, and you're just beginning to see the middle ear bones. If you see that smooth curve right there, that's a middle ear bone. So we'll keep enlarging this. And with the drill, and also lastly, the laser that I mentioned to you, we can break the connection that the middle ear bones have to the surrounding bone, and do that without vibrations very safely. So now you'll see that middle ear bone is free. Here's where we use the laser where the black was. I'm going to show you the facial nerve, how close that is, and I'll touch these middle ear bones, and you can see now that they'll vibrate. So that's the incus, the second middle ear bone. There's where the laser was used. Here is the facial nerve, right there. In this case, there's no bone over it, as there normally is. And then if I touch the middle ear bones, I think you can see that they're now vibrating. So for the first time in this child's life, if we can supply sound to those middle ear bones, they'll transmit it to the inner ear. But to do that effectively, we have to make an eardrum. And we take some tissue from the area under the skin over the top of the muscle called the temporalis muscle that's above the ear, and it actually attaches to the jaw, so it's the chewing muscle. We take a piece about as big as your fingernail, and we transplant that into the ear and attach it to the middle ear bones. It's about the thickness of 2 sheets of paper or so. And it's very tough. Your body will grow into it, and it will get a blood supply, and it'll be a living tissue once the transplant is done. Once that's in place, and then we'll connect it to the middle ear bones, then we take a skin graft to put and line the ear canal, and also on top of the eardrum. And you see on the left side, what I've developed is a machine that will let us take a very thin skin graft. It's actually about 0.2 of a millimeter or 0.3 of a millimeter. And I think you can see, if your image is good, these little black dots, those are actually the hairs that remain in the scalp. So the graft doesn't have any hair in it. And we clean it, as I was doing when you first saw this, and then we place that in the ear canal and over the eardrum. So if you look at this animation at the bottom, what happens is that we take a thin enough piece of skin that all the hair follicles stay in place. And what's nice is there's skin that is in the lining of each of these little tracts where the hair comes out. So when there's hair, all the skin has to do is grow up and then over to the side to meet the other skin that's coming from the next door hair follicle. So it heals really quickly. The other advantage of this is the hair grows back through it completely and you don't see it. And thirdly, it will produce no scar for some reason. We haven't ever seen one keloid or scar thickly in the scalp, whereas taking it from the thigh or the backside or the abdomen or the inner arm, all of those at times will have really thick scars to them. So that's an advantage. And then it's also the most like the skin of the ear canal. Here are some examples of people who, not us, but other folks had taken skin grafts here that's really thick and red. This one healed really well, but you still see a pigment difference. So I just hate to put that in a place where a child may have to explain to their friends if they're ever wearing a bathing suit what that is. So we use the skin from the scalp. And this is the final packing. You've seen this one before. The sponge stays in place for about 2 to 3 weeks and holds the skin against the side of the bone so that the body grows into it and that becomes living. And then we take the packing out. These are patients who have had just an ear canal. We didn't do the outer ear at the same time. So this one, top left, is actually still in the operating room. You still see some of the drapes on. So there's the small incision. These are about a week later. You can see that opening there. You just see a little of the skin graft there. Same thing here. You can see a little more of the skin graft healing there and the hair starting to grow back through it. So we're calling that a microincision canal, which saves more tissue for the plastic surgeon to be able to use and allows them to do a better job with the reconstruction. And this is a young girl who had CAM surgery. She's about 10 minutes after waking up, and I think you can see she's in no pain. And the reason for that is that we inject, before a child awakes, like the dentist would use, a medication which makes it completely numb. Later, as the day goes on, that wears off slightly, and most children use some pain medicine the first day. About half of children need pain medicine the second day, and then rarely does anyone need any the third day. So here's what it looks like on side. This is the sponge that we put in place. So the view you saw before was looking down at the sponge. So the sponge, again, is holding that skin graft in place. There is a sponge behind the new eardrum, and then sponge on top of the new eardrum that holds that in position until it heals as well. We like to have you with us 3 or 4 weeks because air travel and other types of things can move this eardrum. But by that point, we've begun to take all this packing out. So the first week, we take some of it out. And then the second week, we're taking more of it out. Usually this is the time that the child notices that the hearing is really starting to change. And by the way, the hearing will improve for about 4 to 5 months after surgery, where we get our maximum effect. And during that period of time, you'll use some drops and keep it dry. And when you go home, the ear canal will be open. There's still some packing in the middle ear, which dissolves by itself over the next several months. It has antibiotic and it fights infection. And that's when that goes away is when we see the maximum level of hearing. Now, we also like to make a mold of the ear canal. What we found is that, let's put it this way. When we first started, around the world, 30% of the time, when people tried to make an ear canal, it would close. So that's way too high. So we developed a number of surgical techniques which got that stenosis or closure rate down to about 8 to 11%, depending on how you look at that, which is fantastic. But what we found since then is if we make a mold before you go home that's custom for the ear canal with a material that has that causes the anti-scar portion of the body, there's a chemical process in the body that reduces scar. If that kicks that process off, we've reduced the chance of stenosis now under 2%. So all of our patients will wear a mold for 4 months at night when they sleep. And then after that, it's not needed anymore. Now, let me shift gears just a minute here and answer. This will answer some of your questions, I think. People ask me, what's the best here in order from sort of best solution to worst solution. And here's my attempt to do that succinctly. All of the ways that we use a canal plus a hearing aid, or the implantable hearing devices actually will provide sound to a child. So they all get what we want. There are some slight differences that make one better than the other. When you use a implantable hearing device, that device will actually stimulate both inner ears simultaneously. So what that means is complex, and you'll understand more of this if you've seen the other lecture, is to be able to tell directional sound or to be able to hear in noise, you need two separate data streams, one from your right ear and one from your left ear. So the bone conduction devices give the identical stream to both inner ears. So directional sound, hearing and noise are much worse. In fact, you don't get directional sound with a bone conduction hearing device. Whereas with an ear canal or an ear canal and a hearing aid or a certain type of implantable hearing device, you do get all of those. When there is a hearing aid in the ear, or when there is a bone conduction device that comes through the skin, you tend to get infections. The bone conduction hearing devices and all the hearing devices are much more expensive. The bone conduction devices, for example, are about $5,000 to $7,000 US, and they last on average about 4 years. So you're going to put, over an 80-year lifespan, you're going to put north of, 100 to 150,000 US into that device. They break, and the complexity is easiest actually for the bone device. I mean, that's a pretty simple surgery, so that's not tough. And the canal is more complex. This special type of hearing device, implantable, is the worst. So the complexity is the only downside that we really see the canal, whereas all the others are on the upside. And as you see, as we go further to the right, those are less desirable options. Now, not everyone can have a canal. So if you have a score of a 3 on a CT scan, this one is off the list, and this one is off the list. So then we're picking between these two. But that helps you to understand which one to go with, and we'll advise you in case that's just too complex, because that's a lot of information all in one little slide. So let me work toward an end here with some special considerations. The first one is that when we have a normal ear, the ear is self-cleaning. If you see this small black dot here, several weeks later it's here, and several weeks later it's here in a normal ear. So what's happening is the skin is growing in a circular fashion, and it will actually bring all the debris to the outside. So we flick it out with our finger or sometimes with a cotton swab, and we keep the ear clean. When you put a skin graft in, so far I haven't been able to figure out a way to get that skin to migrate. So what you have to do is actually have that ear cleaned. Usually it's once a year. The first year it might be as many as 3 or 4 times a year, but once it heals, it's usually once a year. It takes about 5 minutes. It's simpler than cleaning the teeth, for example, but it requires an ear, nose, and throat doctor locally to you that can use a microscope and take a few minutes to clean the ear. There's like a little thin layer of almost like a wax paper or saran wrap that's taken out of the ear to keep it healthy. As I showed you before, the middle ear bones are quite small. This is the stapes, or the stirrup, you'll sometimes see it called, a very tiny bone. And those are connected in 3 different places. The junction between the second and the third bone is called the incutostapedial joint. And that's the smallest joint in the body. And normally there's actually a little fluid-filled joint with almost like your knee with cartilage in it. It's a tiny little thing. It's about 0.6, maybe sometimes 0.5 of a millimeter. And in a significant percentage of these patients, it doesn't develop correctly. And we were the first ones to realize that when we started to employ this tiny little camera that we could put in the ear. So here's normal with sound coming down the ear canal, and you'll see that as sound strikes the eardrum vibrates back and forth. This is way more than it normally vibrates, but it's just the artwork to show you that. And then that vibration is transmitted through to the inner ear. There you go. So the problem is actually right here. The junction between the second and the third middle ear bones are not connected well. I'm going to move for just a minute as we talk here to get some battery going. So what happens in those cases, instead of there being a joint, there's a little fibrous junction between the two of those, and that will dampen sound. So the sound is not transmitted as well to the inner ear. And what we found is that we can grade that. This is a normal one by example, and you see the joint right there. This is an atresia and microtia. And in a second, you'll see as I touch that middle ear bone there, you see that joint actually flexes and moves a little bit. The stapes or stirrup is down here, and that junction, or that is a normal joint. Whereas in a situation with an abnormal joint, right here, you'll see there's a loss of energy. So there's the facial nerve. This is a middle ear bone called the incus. And then the stirrup has a small tendon associated with it called the stapedius tendon. And right here, focus on this. You're going to get a bigger view in just a second. So right there is where the bone should be on the bone. And I think you can see right here particularly, there's just a little scar tissue between the two of those. So movement of that bone is showing a much diminished movement of this. Watch that again for just a second here. Oh, sorry. So the thing that we've seen is that when the bone is not connected, if we don't replace it, then you'll get improvement in hearing, but not as much as you would think. And that has happened evidently for years. That we knew that a certain percentage of patients, just the hearing just didn't get much better after atresia surgery, and that was why. About a third of patients, actually 30%, have this abnormality. So what we then developed were a number of prostheses that are specific to this situation to reconstruct that. And sometimes we will place those at the first surgery. For example, if we go in and we find that the bones are not connected, we know that it's going to take a prosthesis. Sometimes we go in and the joint's good, like the image I showed you earlier. You certainly don't need a prosthesis in that. And then in some cases, we go in and the joint is partially malformed. And in those cases, we grade them, grade 1, 2, and 3. One of our fellows, Ashley Balaker, did some wonderful research in this area. So we know if there's a grade 1 or even a grade 2 connection, that many times it's enough transmission of sound to get what we want. So we don't replace it with a prosthesis. But occasionally in those patients, we'll see that the hearing doesn't come up as much as we want, and we'll go back to do a delicate but a very small surgery to repair that middle ear bone. And that's the 6% of patients that require a second surgery that I mentioned to you before. Now, I can tell with the CT scan what the bones look like frequently, but not always. So I never know 100% until I actually look at it under the microscope. It takes 10 seconds once I see it and get the bone out of the way, but that's the first really clear view that we get of that structure, which is a fraction of a millimeter and not always visible on a CT scan. Okay, now look at this one. This is important. So this is normal. You see that gray shaded area right there? That's an ear canal that tried to develop, and instead of being open, it formed a cyst. You see me opening that right now. And that cyst is filled with hair and normal skin. It's called a cholesteatoma. And if we leave that over time, then that cholesteatoma will enlarge, as it has here, and it will erode into other parts of the ear. It will sometimes erode into the balance canal, as it's done right here, and it can even erode into the brain and cause transmission of meningitis. This is a rare condition, but it's one that is very important. This is a young girl from Australia who actually had a cholesteatoma. We knew it, we saw it on a CT scan, and it became infected. And you saw here that infection is starting to form an abscess. So one of our excellent colleagues in Australia performed what's called an incision and drainage. Dr. Belle Allen did surgery where we drained the cholesteatoma, settled it down, and then later she had surgery where we removed it and reconstructed the ear. This is another one with starting to come through the skin. And but for this reason, it's really important to make sure there is no cholesteatoma present. This also is one where a surgeon we work very closely with actually put an outer ear in place over a canal, a partial canal, that had a cholesteatoma. And then over time, I think you can see here that the cholesteatoma has grown. It's starting to push the medpore out, and there you see it starting to actually erode through the ear canal. So we had to do this remove the outer ear, and fix this problem. So it's really important for you to know, here's a patient who had one with an outer ear that looked okay. The only way to tell that is with a CT scan. So it is absolutely critical that patients who have atresia and microtia, every single one of them need a CT scan. There are many surgeons, particularly plastic surgeons around the world, who don't know that. The ones we work with do, most of them. And that is, it will come back to you, promise you. We've operated on some people recently who a surgeon put an outer ear rib graft in place, and when the patient was 32 years of age, he comes with a very serious life-threatening problem. So don't make that mistake, and sometimes you have to be the one to ask for the CT scan. All right, let's talk about results. This is the hearing test on the left side as you're looking at it. The hearing nerve, again, is the red, and the right side is the postoperative test. So the green, if you remember, was the sound that was coming in from the outside. So what we've done by opening an ear canal, lining it with skin, and making an eardrum is that we have moved this level from the point that in normal conversational speech, you're not hearing it, to the point that that ear is now functional and sending data to the brain. The other thing I'd point out is we can get into the normal range, but so far it's very rare for us to get up to what a normal ear would be. So if a patient has had surgery, you ask them, which is your stronger ear, they'll say my normal ear. This is a patient with single-sided atresia microtia. But if you say to them, is it close? And they'll go, yeah, it's pretty close. And you say, well, what percentage is it? And they'll say, it's probably 90% of what the other ear is. You'd notice if you put a phone to both sides, a little softer sound, but the sound is clear, it's natural, and you can hear whispers and people on that side. But the test is just a little different. Okay, this is really important for parents. So if you've been listening a long time, and if you're zoning out a little bit, this is a good one to refocus on for a second. This is data, follow-up data on people who had a CT scan with a grade of 6 or 7 or 8 to 10. And it tells us what percentage of people were able to get into the normal range. Now, virtually everyone who has an ear canal surgery, the hearing will improve. Very high percentage of the time. But what I want to see is that ear to come into the normal range. So a CT scan of 8 to 10, 80% of those people will come into the 0 to 30 decibel range. And a CT scan of 6 or 7, remember that's not quite as favorable, 67% of patients will come into the normal range. So when you get down to 4, for example, that gets down to 15% of patients come into the normal range. And 3 or a 2 is virtually 0% into the normal range. Complications happen with every surgery, and these are the 6 that we will see most commonly with this condition. Infection, that's obvious. Anytime you have surgery, you can get an infection. The eardrum can pull away from or move laterally or lateralize from the middle ear bones. So if it's attached, you'll get good hearing, but sometimes if it pulls away, then the hearing will drop off again. We'll see restenosis or narrowing. We've talked about that with the mold a little bit. Hearing loss can happen. We can see an injury to the inner ear or the hearing nerve with surgery. We can see an injury to the facial nerve. So the movement on that side of the face would not be present or would be reduced. To me, that would be potentially the worst case scenario, because that's something the child would have to live with for their whole life. And then lastly, is you can see a loss of the skin graft in the ear canal that requires us to do another surgery and replace it. For example, if the ear's not kept clean or a bad infection happens, then sometimes the skin can be damaged. Now, the next ones are the incidence of that in all of the surgery around the world, which is the worldwide number, and then this is our incidence at the California Ear Institute. Infection, 2% worldwide, really rare to see an infection of the ear canal. We've seen some infections of the outer ear, the midpore, but not the ear canal. About 16% of patients, the eardrum will lateralize worldwide. Because we attach the middle ear bones to the graft, we now have that down to 3%. I mentioned the stenosis rate, which was 30% around the world. With our surgical techniques and the mold, it's now 1.9%, but 2% is a good estimate. Hearing loss, 2%. Rare for us to see that. Facial nerve injury around the world is 1 in 50 people. So far, we haven't had an injury to the facial nerve. And the skin graft loss around the world, about 1 in 6 or 7 patients requires a second operation, but in our patients, about 1 in 50 patients require us to fix that graft. These are a number of papers around the world, if you have looked into this, that look at the success rate, and we're doing quite well compared to others that do this. Now, some advances we've made, you've heard of some of these, but the first one is the canal before the microtia repair. I showed you that paper. The CAM, which you'll hear more about, is a combined surgery with the atresia and microtia repair, which I think is growing in terms of its popularity, and quite frankly, it may be what I would do for my own child. We see the microincision canal surgery, which can work either with rib or PPE. And then the stenosis and lateralization, I think we've made great progress. I mentioned both of those, so we'll go through that. And then the middle ear bone repair is very unique to us. These prostheses are unusual, and in some cases we'll see patients referred to us that say the hearing just didn't come up, the canal looks good, the eardrum looks okay, what's wrong? And many times that's the problem, is there's actually a problem with that joint. The skin graft is an area where we've paid a lot of attention recently. I showed you the machine that takes the very thin graft. And what I was taught originally with some of the surgeons I worked with was to take several pieces of skin and almost do a patchwork quilt of the eardrum and the ear canal. But what I've found is that if you use a single piece of skin and line both the ear canal and the eardrum with it, it's much less likely to drain or have a wet ear. And when you cut that graft to put in, it looks like an angel. It has a body and then has 2 wings that come up on the side and then a head in the middle, which is where it fits on the eardrum, and then the wings kind of wrap around the ear canal. So we've gotten or started to call that the angel graft technique. I told you this earlier, best is canal, next is canal hearing aid, and then implantable hearing devices start to come into place. So now you have a roadmap that should be complete. And if you think of how do I evaluate this, the real waypoint of what to do is that CT scan at about 2 or 2.5 years of age that I like to read. The grade determines whether we go with an implantable hearing device or with an ear canal. And there are 3 ways to do the ear canal: the rib with the canal after, the canal with the porous polyethylene reconstruction after, or the combined atresia microtia repair. You will have a handout, or we will gladly send this to you. On the back of this is that flow diagram, and it gives you a good cheat sheet, so to speak, of how to go about this. There are some other resources I'll mention. Haley, my daughter, and I, you see Haley right here, a little bigger than when she was, some of the pictures I showed in earlier lectures when she was reading. She's wonderful, and I had just a joy working with her. And she and I wrote this book, which is a resource designed for parents. So if you want more information, or for example, if a grandparent wants to read it, this book is either available to you at a conference, or it is also available on Amazon and can detail and give more information than some of the things I've given in this lecture. And then lastly, our website has a large amount of information, including things like genetic syndromes and how to care after care for those of you planning surgery. And its URL is atresiarepair.com. So you can access that if you would like to. One final thing is that we do have also facility. One of the things my wife and I love to do is to make your time with us happy and safe and good. And we have purchased a home that has actually 2 homes attached that can hold up to 4 families, that's close to the office. It has a neat little playroom that we put in there and an area for kiddies to be. Those are appropriate toys for post-operative patients. So there's no like trampoline, for example. And you see some pictures of that. So if you're interested in staying there or would like that, we offer that at a much reduced price compared to local hotels, called the Atresia House. So here's our contact. That's the email, goes to all of us, atresiarepair@cavalier.com. And then the website is atresiarepair.com. So I'd like to thank you for your attention, for the honor of speaking to you. And I hope that gives you a good sense of where we go next. This is a very important thing to customize for each patient. It is not a a recipe. It has to be tailored. And what my goal is for you to understand the nuances of your own child, their anatomy, their development, and what is the best option for you. So I look forward to speaking to many of you either in consultation at a conference or remotely through a Zoom or other type of call from your home. Thank you again.